Okay, perfect. So moving on, there's another slide with warm-up quiz again. So BG of 5.6 millimoles per liter corresponds to 100 milligram per deciliter, 150 milligrams per deciliter, or 200 milligrams per deciliter. What do you think is the answer? Okay, so while I'm waiting, I'm just going to actually just continue giving the answers to just save some time. Yes, Eman had given the right answer, which is 100 milligrams per deciliter. Well done. And then the second question is, children with known diabetes may develop DKA with the normal blood glucose, which is true or false? I'm not able to see the rest of the chat, so I'm just going to say the answer. This is true. And then moving on to the third question, bicarbonate should not be routinely used to correct acidosis. True or false? True. Yeah, perfect. Thank you. And then urinary ketones of 2+. We often say that always measure the bedside blood ketones, isn't it? And some units sometimes not necessarily be able to measure that. So if you've got only a urinary ketones, how do we actually interpret that or correlate with the blood ketones? I found this particularly useful. So the urinary ketones of 2+ corresponds to a blood ketones of 2, 3, 4, or 5. Any guesses? 4. Okay, it's actually 3. The urine ketones must be read 15 seconds or 30, 45 or 60 seconds after dipping the step, after doing a urine dip step. What is the correct answer? It's more for the nursing staff, but it's good for us to know as well. Okay, sorry, if there are no further answers, I'm going to give the answer. We need to read it within 15 seconds. I mean, just after 15 seconds. Yeah. So with this, so what is the definition of diabetes and how do we diagnose diabetes? So I'm just going to, instead of asking this as a question, I'm going to move on to the next slide just to save some time. So we always have to diagnose diabetes by using an oral glucose tolerance test. Okay, so I've got like a stoplight approach for that. For someone, as we discussed earlier, if it's a euglycemic state, fasting should be between 3.5 to 5.6, and a postprandial should be less than 7.8, and the HbA1c should be between 4 and 5.6%. So what is impaired glucose tolerance? It's a reduced insulin sensitivity following an insulin load, a glucose load. And if you think about this, the fasting should be normal, less than 7 millimoles per liter, whereas post glucose load, it should be more than 7.8, but it should be less than 11, because anything more than 11.1 is diabetic range. The HbA1c is between 5.7 to 6.4%. And if you look at the diabetes cutoff, as I have said it here, a fasting should be more than 7 millimoles per liter, and post OGTT it should be more than 11.1 millimoles per liter, and a HbA1c should be more than 6.5%. However, a random glucose of more than 11.1 is also diagnosed as diabetes, and we not necessarily we have to go ahead and do a formal OGTT. So what do we think is the type of diabetes do children get? I guess we all know the answers for this. Majority of them get type 1 diabetes. And why is it important for us to know? Obviously, if we know if it is type 1 or type 2 or any other rare forms of diabetes, then our management depends on the diagnosis really. And we can actually discuss about that in another slide later on. And how does it present? Okay, so we all know that it can present in a pre-symptomatic state. For instance, some children can come in for a routine like a dental extraction or any other surgical procedures, and they may get their blood glucose done as part of the the surgery workup or something, and they may be found to have some high random BGs, and that is something which we often encounter. And then the second thing is the classic symptoms of diabetes like polyuria, polydipsia, weight loss, and or if there is a family history of diabetes, then the family members are easily able to pick up those symptoms and then take them to the GP and so on. And then another form, and the severe form of diabetes presenting, is obviously DKA, and we will come on to that in the next slides. So how about the incidence? As we discussed earlier, the majority of them, 97% of them, have got type 1 diabetes, and the rest is shared between type 2 and rare forms of diabetes. And also the prevalence is kind of 1 in 1,000, and as we go along, we see that there is an increasing rise in incidence in children less than 5 years of age. So type 1 diabetes is primarily because of the autoimmune beta cell destruction. Thereby, there's no insulin production, and that's why it's important for us to know this so that these children are treated with insulin. Whereas the type 2 diabetes is either because of the progressive insulin secretory defect or leading to very low insulin production, or due to the insulin resistance and because of the associated obesity. And obviously the management varies for that, and they all have to be managed with diet and exercise and metformin. And metformin is basically a biguanide, and what it does is it reduces the hepatic production of glucose, basically gluconeogenesis, and it also actually increases the insulin resistance. And some children, especially, sorry?
Insulin sensitivity.
Oh yeah, and it increases the insulin sensitivity. And then some children may need insulin as such, and there are some newer therapeutic options available nowadays, which is liraglutide. It's basically a glucagon-like peptide 1, and what it does is it actually decreases the glucagon secretion and increases the insulin secretion, and thereby increases the insulin sensitivity as well as its levels. So what are the actions of insulin? So the way I tend to remember is insulin acts as a key. So if you think about a cell as a house, we need a key to open the house. Like that, we need the insulin to open the cell for the glucose to enter. So what happens is, as it's nicely shown on this cartoon, so we have a high glucose meal and our blood sugars are high, and that promotes, I wanted you to follow the yellow arrow here, and it promotes the insulin release from the beta cells of the pancreas, and that causes the glucose uptake from the blood, as well as the remaining is converted into glycogen and it's stored, and thereby the blood sugar levels are lowered. On the other hand, when the blood sugar levels are quite high, very low, then we need more glucose, obviously, and that promotes the glucagon release, and also that then stimulates the breakdown of glycogen, that is the gluconeogenesis. So what goes wrong in type 1 diabetes? So we know that there is insufficient or absent insulin that results in alternative sources of energy by lipolysis and proteolysis. As byproduct, we get the ketone bodies, and the increased ketone and glucose in bloodstream as a result of which sometimes, in severe cases, these children present with DKA. So how do we define DKA? We all know that a BG should be more than 11 millimoles per liter, and the pH should be less than 7.3, and the bicarb should be less than 15 millimoles per liter, and ketone should be more than 3 millimoles per liter. And this is how we define DKA. So what goes wrong in DKA? So there's too much of sugar, but in the wrong cells. So there's deficiency of insulin, and there is an excess of glucagon. Thereby, we have high blood glucose levels. And we all know that glucose is an osmotic diuretic. So that results in fluid and electrolyte depletion that can cause shock. On the other hand, there is an increase in blood ketones, and that again contributes to the osmotic diuresis, leading to shock. And ketones per se is the reason for nausea and vomiting. Again, that contributes to the fluid and electrolyte depletion. And then the ketone bodies are basically acids, so that results in the buildup of acids that causes cellular dysfunction and death. And both acidosis and fluid and electrolyte depletion can contribute to cerebral edema. So why does DKA matter? So we all know that, so cerebral edema is the biggest, the cause of death in DKA. Nearly 25% of, the mortality is nearly 25% in children who got DKA who developed cerebral edema. So I'm not a radiologist, but even I can actually, basically see from the first slide that there is absence of sulci and gyri, and there's a progressive, cerebral edema. And I'm not sure how you are able to see these, and all these, the little, like a calcified white dots, they're all signs of infarction. Actually, this is a 14-year-old boy who I've seen in Manchester who had presented with severe DKA, and unfortunately, actually, we lost him because of the cerebral edema. That was several years ago, though. So why is it important? And who are where is it? Who are the children who's more prone for developing cerebral edema? The younger, especially children less than 2 years of age. And often it's a first presentation, like diabetes presenting as DKA. And if it is severe and longer the duration of diabetes, then the more likelihood of them developing DKA. And early insulin treatment, we all know that, we need to actually replete the fluids first, and usually to start the insulin after 1 to 2 hours of repleting the fluids. And if not, and if we start them on insulin straight away, then there is a risk of cerebral edema. And as we saw in the first slide, if we actually, I don't think any of us treat acidosis with bicarbonate. However, if it is done, then again, that can be a contributory factor for developing cerebral edema. Having said that, bicarbonate can be given in severe hyperkalemia, or if there is an impending, risk of myocardial infarction. But I've not seen or experienced, anyone using bicarbonate in my clinical practice so far. So how do we manage DKA? I've given a list of, useful guidelines and resources, but the one at the top is our National British Society of Pediatric Endocrine and Diabetes Guidelines, and we're all expected to follow that if you're practicing in UK. So what are the main principles of management? As with any resuscitation scenario, in DKA, we always have to tackle them with A, B, C. And again, monitoring the electrolytes closely, especially sodium and potassium, and fluids. Fluids first. followed by insulin after an hour, and then always have to think about complications. The complications can be in the form of electrolyte imbalance, or if it is associated sepsis, or if the close monitoring for them developing cerebral edema, so that we can identify that early. And there are other severe complications or different types of presentation, which we can look at it in the later slides. So in the next 2 or 3 slides, I'm just going to summarize the key changes in the BSPED 2020 protocol, which is different to the previous one in 2015. So the definition, as we discussed earlier, the pH should be less than 7.3, or the bicarbonate should be less than 15 millimoles per liter, and the ketone should be more than 3 millimoles per liter. And obviously the blood glucose should be more than 11 millimoles per liter. And previously, we used to categorize DKA as mild or moderate and severe based on the pH of less than 7.1 or more than 7.2. More than 7.1. However, there are further stratifications to that now, and we have now 3 forms, which is mild is anything between 7.2 to 7.3, and the bicarb should be less than 15 millimoles per liter, and the dehydration is kind of assessed based on that as calculated as 5% dehydration. And the moderate is between 7.1 to 7.2, and the bicarb should be less than 10 millimoles per liter, and the percentage of dehydration is estimated as 7%. If it is severe, pH should be less than 7.1, and the bicarb should be very, very low, less than 5 millimoles per liter, and the dehydration should be 10% estimated. And we no longer use inotropes. However, if someone is coming with severe shock and needing fluids more than 40 mils per kilo, then we still have to think about it. But again, that has to be in discussion with the intensive care team. And in terms of the bolus, in the previous protocol, based on the assessment, we used to give 10 mils per kilo, and then we used to subtract that. However, in the current protocol, we have something like a resuscitation bolus, which is based on the shock. We can give to a maximum of 20 millimoles per kilo bolus, which is obviously 0.9% saline, and we can give up to a maximum of 40 mils per kilo. And then we can consider the inotropes, as I stated earlier. However, this bolus is not subtracted. Previously, we used to subtract any bolus we give to the children with DKA. And then as soon as we corrected the shock, then we actually assess them, and depending on whether they are not in shock, then all the children get an initial 10 mils per kilo bolus for 60 minutes. And this bolus should be subtracted from the calculated fluid deficit. It's a bit tricky to present this in a kind of a virtual platform. So I'm not sure, whether you got any questions. Probably at the end of the next slide, I will go to the chat section and check if you've got any questions. And then moving on, young people, it's very simple. If an young person between 16 and 18 years of age, if they come to us as pediatric A&E, then we follow the BSPED protocol. On the other hand, if they go to the adult world, then they will manage the DKA as per their guidelines as appropriate, and there's no need for us to kind of confuse between the two, rather to stick with one and do that properly. And then the maximum weight is 80 kilograms for fluid calculations, so that we are not fluid overloading them depending on their weight. And if the potassium is high at presentation, we no longer add potassium to their IV fluids unless and until they've passed urine, or the level have fallen to the kind of the lower, normal range, basically. Upper lower. Yeah, say for instance, like, I mean, the normal range is between 3.5 to 5.5. So if it is like 3.4 or 3.5 or 6, then we tend to add. As long as it comes to.
So sorry, just to clarify that, as long as it falls within the normal range,
Yeah.
even if it's the higher normal range, at that stage you would add potassium. So you don't wait for it to fall lower than that.
Oh yeah, sorry. Yeah, it's the upper end of the normal range, which is like, I mean, closer to 5.5. My apologies. And then in terms of the long-acting subcut insulin, like, I mean, this is something new. Like if a patient is a known type 1 diabetic who's already on long-acting subcut insulin, then the guidelines say that, like, I mean, we continue that. And then the new patients, we can consider starting alongside IV insulin. However, I think it varies on, individual units. In our unit, we tend not to do that. However, if you prefer to do that, then please discuss with your endocrine consultant prior to doing so. And then I put it as a default infusion rate as 0.05 units per kilo per hour. And this can be adjusted and gone up to 0.1 units per kilo per hour if required. And when I say by default, this is for younger children less than 5 years of age, and for children who are presenting with mild to moderate DKA, i.e. their pH is more than 7.1 and less than 7.3. However, if these children, they need, and if they're not responding or if their acidosis is not resolving and if they are not switching off their ketogenesis, then obviously we can actually increase their insulin to 0.1 units per kilo per hour. So why did we actually change all these? What is the reason for us to actually change our BSPED DKA guidelines between 2015 and now? This is based on this seminal paper, which was published in the New England Journal of Medicine in 2018. What they basically have done is, it is a randomized control trial, and they have actually kind of recruited 13 centers, and they've actually recruited around 1,400 patients into this trial, and all children less than 18 years of age who presented with DKA. And they have actually kind of categorized them into 4 groups as a 2x2 like factor table. And what they've done is basically they've compared between the rate of infusion as well as the concentration of sodium in the fluid. So if you look at the slide, so their inclusion criteria is, as I said, between 0 and 18 years with a diagnosis of DKA. And they have basically excluded children with severe DKA or any other head injury or any other, they are receiving any substantial treatment, or who presenting with a GCS of less than 12. And so the main categories are slow infusion and the fast infusion, and each of them is again then subdivided into 4.45% saline and 0.9% saline. They buy 2 groups within each group. So in the slow infusion group, they gave 10 mL per kilo fluid bolus, and then they replaced the the 5% deficit over a period of 24 hours. Whereas in the fast, they gave them a much higher bolus, and they also actually replaced the fluids like as based on the 10% deficit within 12 hours, and then the half of which is then replaced over the next 24 hours. So the primary outcome, what they looked at is like 2 consecutive fall in GCS less than 14 within the first 24 hours of treatment. And the secondary outcomes is by, any apparent brain injury or a short-term memory, during treatment, and also like kind of like after 2 to 6 months of DKA, what is their IQ levels. And the most important thing is, they found that there was overall, there's a decline in GCS to less than 14 in 3.5% of the NTA study group, and in between the 2 groups, there are no difference at all whatsoever. And then again, they found a 0.9% of clinically apparent brain injury. And again, there were no difference between the two groups. So the bottom line is like, I mean, neither, the rate of fluid administration nor the change in the concentration of the fluid, whether it is not 0.45 or 0.9%, did not actually lead to any worsening of any of the primary as well as the secondary outcomes actually. So fluid administration, we always feared, and in the previous protocol, we always actually kind of fluid restrict them in view of fear of cerebral edema and brain injury. However, that's not the case. So who needs HTU and PICU? Obviously, if they are very young, less than 2 years of age, or where they have severe DKA, less than 7.1, or if they have very high BGs at presentation, more than 30 millimoles per liter, or if they have significant electrolyte abnormalities in the form of hypo or hypernatremia or hypo or hyperkalemia. Again, if they have any evidence of impending cerebral edema or altered consciousness. So I'm just going to kind of, just check with everyone. Like, I mean, do we have any questions prior to moving on to the case scenarios? Katie have posted a question. If they weigh more than 80 kg, should we use ideal body weight or just 80 kg to calculate the fluids? We just use 80 kg as a maximum, not the ideal body weight. Is that okay, Katie? If there are no further questions, then shall we move on to the case scenarios?
Yeah.
Are we okay with the time?
Yeah, you got it.
Okay, fine. So our first patient is a 9-year-old girl by name Sweetie, and she presents with headache and abdominal pain, with a 2-week history of these symptoms, and she wakes up in the morning with abdominal pain and headache, and she's been drinking more, and she's polyuric, and she is waking at night even to drink water. And she's still managing her daily tasks, but just feels that she's not having as much energy as she used to have previously. So what else would we like to know, and what do we do next? I think in the interest of time and in the, being a virtual session, would it be okay if we move on to the next slide? Yeah. So I'm just focusing on diabetes here, and obviously we need to think about other systemic conditions in this child, but now focusing on the diabetic. Her urine glucose is 3 pluses, her ketones is 3 pluses, and there are no leukocytes and no nitrates, and her random blood sugar is 22, and her blood ketones is 2.2. And we did a venous blood gas, and a pH shows is 7.35, and a base excess is minus 0.7. And her glucose is 23.1, and her sodium is 134. We think it's on the lower side, but the key message on this slide is like, I mean, any child who presenting with diabetes or DKA, whenever we do a blood gas or the usinase, we have to make sure that we are correcting the sodium, because the sodium what we see is apparently low when compared to the actual sodium is because of the high glucose content. And the potassium is 4 in her case, and the lactate is 1.5. And the lab sodium is 134. I've put the formula to correct the sodium here. So the corrected sodium is plasma sodium, which is 134, plus glucose, which is 23, and minus 5.6. That is a mean normal blood glucose expected in any child. So it's basically how we derive 5.6 is the normal BG is between 4 and 7. The mean of that is 5.6, and that is equivalent to 100 milligram per deciliter. And you divide that by 3.5, and that gives you the value here as 139 millimoles per liter. And the corrected sodium, we have to be very careful in monitoring the sodium in children with DKA. because it should be very, very appropriate the way we correct it, and it should not go beyond 0.5 to 1 millimoles per hour with treatment. If you think like, if the sodium is going, rapidly going up, then it's an indication that we are not correcting or we are not correcting the shock, or we are not correcting or giving adequate fluids to that patient. On the other hand, if there is a rapid fall in sodium, then that indicates that we are giving them too much of fluid, and that is why there is an expansion of the ECF volume, and thereby there's more of a dilutional hyponatremia, and that means that we need to slow down with our fluid resuscitation. Yeah. So what is the diagnosis and what do we do next? And we all know now. So we admit the child and we actually do a type 1 diabetic screening bloods. I've just given a list here so that these sessions are recorded as well as saved so that it is useful for your future use as such. And in terms of, I just want you to focus on the antibodies here, which is I'm not sure whether you are able to look at the pointer, anti-GAD, anti-zinc T8, and anti-IA2 antibodies. These three together are called as triple antibodies, and these are the antibodies we test in our labs nowadays.
So she's in DKA.
Yeah, she's not in DKA, so we then start her on insulin 1 unit per kilo per day. So, which is, this is just to kind of highlight if a child is presenting with type 1 diabetes but not in DKA, how do we manage them? Yeah, because we all know that if anyone comes with DKA, we do have a BSPED guidelines to refer to, and then it's very easy to follow the DKA guidelines. On the other hand, if they don't have DKA, then how do we manage them? So we generally start them on insulin 1 unit per kilo per day, and then half of which is long acting and half of which is short acting. In her case, I've given 7 units PD based on this child's weight. So this is not a set dose whatsoever. Please bear that in mind. And then we give them set dose of Novorapid. For this child, we calculated 5 units with meals. So basically, this child weighed 30 kilos. Okay, so then 15 is Levemir, which is long acting, which we divided that into half to give 7 units PD, so total of 14 or 15. And then the Novorapid 5 units, and then by day 2 or so, we can then start carb counting for them. And then correction doses of Novorapid is given for BGs more than 10. Again, we can actually go by the individual patient and their weight for that. So the aim is to maintain the BGs between 4 and 7. And we always have to check ketones if the BGs are more than 14. And the way we actually monitor the BGs are pre-meals and 2 hours post-meal during the day and every 3 hours during nighttime. And whenever we give an insulin correction, we should not correct it within 2 hours of administration of Novorapid. And we all know that, 4 is the floor for diabetes, and if the BG is less than 4, then depending on the weight of the child, we can give them between 5 and 15 grams of glucose juice. So for instance, any child more than 40 kilos, we give them 15 grams, and we always recheck in 15 minutes. And then we have to involve the diabetic team, the anti-diabetic team, nurses, dietitians, psychologists, and all for ongoing diabetic education. So we move on to the next question. Next patient, who's Toffee, who's an 8-year-old boy. Again, he presented with weight loss over a period of 4 months from 55 to 42 kilograms, and he had some reduced appetite over a period of 3 weeks. And he developed some tooth infection for which he completed antibiotics. And then that week, he was a bit more sleepier than usual, and he was seen at a private center. and his baseline bloods were done at 10 a.m. that morning, and then the patients were actually emailed their results at 2 p.m. that the random BG was 19 millimoles per liter. So they called the ambulance, and then because of the long waiting hours, the parents themselves rushed into A&E. And so if we are in A&E, and what do we do next? Again, I'm going to move on to the next slide in the interest of time. So he had a venous blood gas of pH of 7.23, and his bicarb is 13, and his glucose is 21.6. and his ketones is 7. So if you follow the little table what I've given here, whether it's mild, moderate, and severe, so we know that the pH is between 7.2 to 7.29, and the bicarb is 13, less than 15 millimoles per liter, and his glucose is more than 11. So his mild DKA, and we know that we estimate as 5% dehydration. So what is the diagnosis and what do we do next? So, sorry, I just put it that, we know that, we follow the DKA protocol for that. And because it's, so we give, he's not in shock, so he does not need any resuscitation bolus. But based on the new guidelines, we need to give him 10 mL per kilo bolus, and followed by our usual DKA protocol, fluids first, based on his weight. I mean, the important thing about the fluid calculation is, when compared to the previous DKA protocol and the current protocol, is we calculate the 100% maintenance, how we do for any child, say first 10 kilos, 100 mils per kilo, 10 to 20, then 15 mils per kilo, and then more than 20 mils per kilo, 50 mils per kilo. It's the same formula we apply for children with DKA when compared to the previous protocol. So based on that, and if we give any bolus, then we deduct that, and then we replace the fluids. Within after an hour, then we start them on insulin, and then we monitor. How to monitor the DKA, I've got a couple of slides later, we will discuss at that time. So moving on to our third patient, Mars is an 8-year-old girl who presented last year. So, so she presented with a chest pain and without any injury, and there are no history of any fevers, and there's no cough. And she went to the local ED the previous night, and then she was assessed, and she was thought to be having some costochondritis, and she was given some painkillers, and she was actually sent home. Yeah. And then the next morning, she attended her A&E, and because of the increased work of breathing, which was getting worse, and at that time, more history was taken, and it turns out to be that, she's polyuric and polytypsic, and she is nocturic as well, and she's more tired than normal. So on examination, she was clinically dehydrated, and she had cold peripheries, dry mucous membranes, and her, her chest was clear, but abdomen soft and non-tender. So moving on, her blood gas pH is 6.87, bicarb, so which comes to the severe category, and her bicarb is 5.7, which is borderline, and glucose is 27, very high, and then the ketones is 5.5. So what do we do next? Again, because she's severe, so we estimate her dehydration is 10%. And so we gave her a 10 mils. This child is managed based on the previous protocol. So I've just given the management as it was done at the time. So she was given 10 mils per kilo bolus, and she was her dehydration was corrected over 48 hours, and she was started on insulin 0.05 units per kilo per hour. And a repeat blood gas, showed a pH of 6.892 and the glucose is 27 and the ketones were 4.99. And then slowly, it's improving, but not at a great deal. And if you could see that the ketones, she's not switching off the ketones at all. So if they had discussed this patient with us at this point in time, we would have actually advised to increase the insulin to 0.1 units per kilo per hour. As we discussed earlier, this is a classic time, where we always have to constantly think about, once we start given adequate fluids and once we started them on the management, if there is no improvement and if the patient is not switching off the ketogenesis, then we have to think about, did we give enough fluids to this child, or do we have to increase the insulin, or is the patient is actually septic, and do we have to address that and all? So we always have to keep a close eye on this. So I put in a slide, how do we monitor children with DKA? It's important for us to maintain a strict fluid balance for them. And we need to if 1 hourly BGs and 1 hourly neuro-ops, and then 2 hourly blood ketones and 4 hourly USNEs. And hourly, the blood pressure and basic observations again. And if we think if they are in severe DKA, or if they are, more prone for developing cerebral edema, like children less than 2, then we have to do the neurological observations every half hour. Okay, and we all know that, if there are symptoms of headache, or if there is an altered consciousness, or if there is Cushing sign, then we have to alert the medical staff. Us immediately, but this is for the nurses. And we've discussed this already. So moving on to our final patient. Bounty is a 15-year-old girl. She presented to A&E, I think Christmas last year, with a 4-day history of being unwell, sleepy, and reduced appetite. And she gave a 4-week history of polyuria, polydipsia, with a weight loss around 10 kilos. And she's also drinking lots, around 3 liters per day, and she's passing urine even at night times. She did tell her parents about polydipsia, but helpfully they asked her not to drink too much of fluid before the bedtime. And then because when she alerted the parents about weight loss, they said they were not too worried about it. They rather thought, okay, this is a healthy weight loss for her. However, then she reached a point where she has to be brought in by ambulance, very tired and drowsy, and the BT with LAS was more than 30 millimoles per liter. We know that more than 30 is a very significant number. So on arrival, she was maintaining her airway, and she's not particularly having any chest symptoms, but her cap refill is 4 seconds. She had sunken eyes. And she, for her age, it's a slightly lowish blood pressure, and she's tachycardic, so she is in shock. And her GCS is maintained so far. And she did have a ketotic breath, and she was very emaciated, no wonder, because she lost around 10 kilos. However, her ketones is more than 7.1. And her blood glucose is 36, and she was apyrexial. And her initial blood gas, is pH of 7.225, and the bicarb is 16.9. So we know that if it is mild, the bicarb should be more than 15. If it is mild, the pH should be more than 7.2. So, and then the glucose is quite high, though, 48, and then ketones is quite high as well. So what do we think she has? So based on the table, we would categorize her as mild DKA, or between mild, mild to moderate, but then again, she is severely dehydrated and she is also in shock. So any thoughts on this? I'm going to actually open the chat column for this just to check anyone. Oh, there are some questions which we can address at the end.
Yeah.
But for this patient, like, I mean, what do we think is the diagnosis? Severe. Sabira has replied severe. Yes, Sabira, it can be severe. And any other thoughts at this stage? Because ketones are very high, yes, but then the pH is kind of mild and the bicarb is not particularly, low. Okay, so other ketotic, okay, yeah. Any other thoughts? If not, we can move on. Okay. Severe ketones due to starvation, yeah. Severe according to dehydration or mild with show, shouldn't change your management that much. Okay, fine. So with this, let's move on and we will discuss that. So we started her on the DKA management. Again, this is based on the previous protocol. Because of the severity of the shock, she received 2 mL per 2 boluses, and cap refill improved after that. And she was started on 50% maintenance with 10% dehydration for 48 hours. Again, this is based on the previous protocol. And she started on insulin appropriately in after an hour. And however, the most important thing is 2 hours into protocol, her sodium is 180, which then went up to 184, which is like more than like 2 millimoles per hour. We all know that from our previous discussion. We want to kind of increase the sodium not more than 0.5 to 1 millimoles per hour. So that means that there is a significant increment in sodium. Yeah. Okay, and her osmolality is because of the very high sodium, then the osmolality was calculated, which is 384. So, we all know that, like, I mean, our normal plasma osmolality, the magic number is 300, the accurate number is 290. So in her case, we know that it is very high osmolality and very high sodium and very high glucose. So what is the diagnosis now? Any thoughts? Honk, yeah, what is a new name for honk? Well done, Helen, thank you. Yeah, we are moving on to the next slide. So the other name for honk, or the new name, is hyperosmolar hyperglycemic state. So that means that the osmolality is very high and the blood glucose is very high as well. So this child, I'll come on to the, the definition of HHS and how to differentiate. But then I'm just going to discuss the management here. So she was catheterized and she started having frequent neurobes and the rest of all as discussed earlier. And she was immediately moved on to HTU, and all the GOSH renal team and endo teams were all informed, and she was transferred to PICU without any further delay. So based on the diagnostic criteria, if you think about the DKA, the pH should be less than 7.3 or the bicarb should be less than 18, and the ketone should be more than 3 millimoles and the glucose should be more than 11 millimoles per liter. Yeah. And in her case, the initial pH was 7.225. Yes, it's low. And then the bicarb is 16.9. Yes, it's also less than 18. However, the sodium is 168, which is very high right at the start. And the glucose is very high, more than 48. And the ketones is more than 7.1. So this kind of fits in with the DKA per se for now. And then let's look at the HHS here. So the pH for HSH should be more than 7.3. Yeah. So this child had a borderline pH, and the bicarb should be more than 15. Yeah. So she passes that criteria. Oh dear. It houses HP, so that's handy. So the ketones is less than 3 millimoles per liter in HHS. However, in her case, it's more than 7.1. Okay, and the glucose is more than 40 in HHS, and the osmolality is very high, more than 320. Altered consciousness or seizures, which our patient did not have, and hypovolemia. So our patient had a kind of this is a very rare case. And the reason for us to present this case is to kind of highlight what is HHS. And this child had a combination of both actually. So she's not typical HHS, but then that evolved actually when we started managing her as DKA and the sodium starting to go up. And we think partly because she, even though you remember in the first slide, I mentioned that the parents kind of asked her to restrict the fluids. She was drinking less, but actually she was drinking more sugary, high sugar content fluids actually, and that pushes a blood glucose to more than 40. Again, that is something, if you look at the pathophysiology of HSS, that's something is often not. Yeah, it's often not, explained very clearly. However, the underlying thing is about the very high blood glucose levels, and also the production of counter-regulatory hormones like more cortisol and more glucagon production. These are the key mechanisms involved in the pathogenesis of I prefer to call it as HONC, to be fair. So so this child had a typical mixed picture of DKA and HHS. So the main difference is to correct the hypovolemia and to restore the renal perfusion more rapidly rather than a kind of slow approaching DKA. And in terms of the volume, we have to give them fluid boluses, and we have to assume dehydration much higher than 10%, and we probably have to replace it within 24 to 48 hours rather than a standard 48 hours DKA approach. And normally we do not replace urinary losses in DKA management, but HHS is where we have to replace them for ml per ml, and that is with 0.45% sodium chloride, which we know that it's a hypotonic because their sodium is very, very high. And we always have to make sure that they're on regular maintenance fluids as well. So in terms of the sodium, so initially, from 0.45 to 0.75% sodium chloride in KCl. And then only if they are hemodynamically compromised, then we use 0.9% sodium chloride. Again, as we discussed earlier, correct the sodium gradually. And if it is not possible, and then we may have to go through the dialysis route. So the management, you aim for the blood glucose to go down by 3 to 4 millimoles per hour, and add 5% dextrose or 2.5% dextrose if the glucose is falling at a rate of more than 5 millimoles per hour, and insulin is only started if the glucose is less than 3 millimoles per liter per hour. Okay, sorry, we do have only 5 minutes left, so I'm just going to rush through the slides, sorry. So so this is just a summary slide for you to actually go through in your own time. This is all discussed earlier, just for your future records, really. So the take-home messages is the new BSPED DKA protocol is actually absolutely fantastic, and it just goes through everything, not just flow chart, but all the possible mechanisms and the pathophysiology and everything. So it's a very good learning tool for us to understand about DKA management. And then always we have to remember to give fluids before insulin, and monitoring the response to the treatment is the key. And it's probably one of the top hits in this slide, because it's just not about starting them on insulin fluids. It's very, very close monitoring between every 2 to 4 hours, and make sure that we are switching off the ketogenesis, and making sure that we've adequately replaced the fluids, so that in case if we need to modify our management. And always watch for signs of cerebral edema, because we all know that it kills. And then high BG with the lowish ketones and not so acidotic but a high sodium, think about HSS. The way I remember is in DKA we have high BGs and ketones and acidosis, whereas in HHS there will be very high blood glucose but the ketones and the acidosis is not that severe, partly because HSH is more common in type 2 diabetes rather than type 1, and they do have some insulin reserve, and that is the reason for them not to kind of have very very high ketones. So that's the reason for that. So this is a kind of a summary slide, and again this is available in DFTB, and this kind of gives in a much more easy way of all the new changes and in DKA management and protocol. So this is something for you to kind of even keep it in your mobile for easy reference. So we are just going to have like very less time for discussions, but we will still aim to do that now. And let's go on to the questions. Oh, so many people have answered HHS. Thank you. Well done. And please, could you show the first slide of HSS management again? Of course, we can. And okay.
Why don't we answer all the questions?
Yeah,
first,
let's do the.
Can be.
Yeah. So, okay. Yeah. How often should you check ketones when BG is more than 14? Whenever, during the management of diabetes, whenever a BG is tested as more than 14, then you check the ketones. And if it is high, then again, we have to keep monitoring it every half an hour. So
just to answer that question, it depends on how you identify it. So if you've got a child who's on MDI treatment, who isn't in DKA, who's just having pre and post meal blood glucose monitoring, if the if the blood glucose is above 14, you check the ketones. If the blood glucose is above 14, you would be giving a correction, and you'd want to check if the ketones are above 1. You'd want to check to see that there's a response in treatment. So normally after we give a correction of insulin, we check the ketones and the blood glucose 2 hours afterwards. In DKA, we should be checking the ketones at least 2 hourly. And in severe DKA, if you're concerned about response, you can check them hourly. In terms of the question about how feasible we think half-hourly neuroobs are given, yeah, DKA is extremely intensive management. So if you've got severe DKA, you need to think about where these patients need to be managed. So they need one-to-one nursing in severe DKA. So if you're in that remit, then that individual will need half-hourly to hourly neuroobs. In terms of diagnosis of diabetes, fasting blood glucoses, yes, we would tend to use it more with regards to suspected type 2 patients. So any patient that's referred to us with suspected type 2 diabetes, we would aim to do an oral glucose tolerance test to look not only for impaired glucose tolerance, but also to see whether they've got insulin resistance. So why do we do fasting rather than relying on several random blood glucoses?
Would you always do fasting?
Yeah. Would you always do fasting? Yeah. So, I mean, if you've got random blood glucoses that are clearly above 11, then that is already, diagnostic. Well, if they're random, so if they're postprandial above 11, then that's diagnostic 2 hours postprandial. If they're above 14 at any point, then that is diabetes. You don't need to worry about doing fasting glucoses. Any other questions at all?
Severe.
Yeah, that's fine. That was the answer.
Okay.
Fine. And I think all the slides should be available to everybody. Is that correct?
Yeah, I can't see any slides from where I can view it. This session is recorded, so you should be able to see all the slides. But when we went through everything, we believe that everyone was able to see all the slides.
Essentially, the BSPED guidelines have really clear guidance on DKA and HHS management. So refer to those if you have any further questions. You're also very welcome to email us if you have any further questions beyond the presentation. And yes, we'd be very happy to give more endocrine talks. Oh, accuracies, measuring glucose between, yeah, I mean, they're pretty good. We always like to have a lab glucose, for the initial diagnostic blood, so we have a clear record of that. But otherwise, measuring the blood glucoses on the bedside machine or by cap gases are fine. It's more about the trend, really. Yeah.
Yeah, we'll show the first slide of the HHS as someone asked. 1 minute.
A parte che ti piace pure come artista, ti è sempre piaciuto, quindi cioè, non è un artista random per te, è proprio uno a cui tu già mi...
Sorry, can't hear you. Do you mind just typing it? This is
Go down. No, go down.
And I think he wanted the first.
The management, yeah.
Yeah.
Okay, I think that's it. Yeah.
Yeah, is this the first slide you wanted to see for someone called AG? Yes, thank you. Yeah, perfect. Okay, so if there are no further questions, then we could actually close the session. Thank you for listening. Yeah, thank you. Please fill in the feedback sheet. Shall we stop the recording now?
I think so.